think let us start. Then people will be joining in between. There was some technical glitch, so we can start. Yes. So, good evening to all, and welcome to all the students of the Jaipur Surgical Tutorial Undergraduate Online Teaching Program. With due respect to my mentor, Professor V.K. Kapoor, for initiating this wonderful online teaching program, especially for the MBBS students and also the postgraduate students, because the curriculum is almost the same, with the sole intention of selfless teaching program for the undergraduate students, basically from the entire country, and also students from outside the country have also joined in this platform. And also special thanks to Dr. Avinash and Team Dwarka Clinic for providing an online platform, which is now a very tedious process. And for this wonderful teaching program. And today with us we have none other than teacher of teachers, that is Prof Banabihari Mishra. He is my teacher also from SCB Medical College, Cuttack. So he will be teaching us about examination of the abdomen. Students, as you all know, examination of the abdomen, if you cannot just describe it properly and also do the examination in a proper way, then definitely nobody will like in the exam at least to give you any mark. So all of you concentrate, and all the questions which are coming to your mind, you can put in the chat box. I will be taking them one by one in the lab. Over to you, Professor Banabihari Mishra. Please.
Thank you, Prakash, for your nice words. Regards to Professor Kapoor. I'm really happy that I've been privileged by giving a call by Prakash to give a presentation on examination of the abdomen. Last week I could not do it because of the vacation, but this week I told that yes, I will be ready. I'll come to the topic right now. But if you see, probably there is a big word that abdomen is a big magic box. And when we clinicians examine the abdomen, we must behave like a magician to discover the wonder inside. My topic will be dedicated as the examination of the abdomen today. And if you see this, I'm a firm believer of this statement by Einstein that education is not the learning of facts but the training of the mind to think. In reality, if I show you the roadmap, probably you can capture the territory. I'll try to devote my way to just give some salient points on the examination of the abdomen so that you can follow it well. This is a wonderful statement already written. If you see the belly and law, probably it is written in the past pages that if you want to be a clinician, you have to follow this, that to study the phenomenon of disease without books is to sell uncharted sea, while to study books without patient is not going to the sea at all. In coming few more minutes, I'll be covering this topic under these headings. That unless you know that what is the anatomy of the abdomen, what is the general examination of the patient as a whole, probably we cannot come to the local examination of the abdomen. The plan is very clear that I will be discussing the relevant anatomy and physiology of the abdominal quadrants, and whenever we want to go for a diagnosis in the abdominal examination of the abdomen, always it's a local examination plus a regional examination plus a global examination. That means we are seeing the patient as a whole, not by a part. And always this abdominal examination under the heading of inspection, palpation, percussion, auscultation is not complete unless we do a per rectal or a per vaginal examination. The essence of the clinical examination one has to understand, because over years what I have analyzed that when we were students, where hands were everything. It was the hand to examine, giving information about the mass or any disease inside the abdomen. So today everything has been replaced by the ultrasound, CT, MRI, all those things. And both teachers and students, they have also thought that probably these things can replace the clinical examination. But my philosophy is very clear that investigations are additives, but never, never, never substitute. So the A sense of clinical examination is it has a key role in the diagnosis. It gives diagnostic clues regarding most abdominal pathologies, and a well-performed abdominal examination decreases the need for detailed radiological investigation. That means, after making a good clinical diagnosis, we choose the needed radiological or endoscopic evaluations. First of all, if you see, this is a picture which shows that the quadrants. The abdomen is divided into four quadrants. There is the right upper, right lower, then comes the left upper and the left lower. Why it has been divided? Because to each quadrant, the organs are also placed accordingly. Somebody comes with a right quadrant, upper quadrant pain or tenderness, we will have to think of all the viscera which are in this area, and accordingly keep in mind that probably the patient is having complaint regarding some of the viscera sitting inside the area, this area. Now, if you see this picture, whatever I have showed you, it is showing that in the right upper quadrant, probably, see, this is the liver, stomach, gallbladder, duodenum, right kidney, a part of the pancreas, and the flexor, and a part of the right colon is there, including the right adrenal gland. Come to the left. If you see to the left, again the left lobe of the liver, adrenal, stomach, kidney, pancreas, spleen, transverse colon, and the small intestine. Likewise, if the patient is coming with a right lower quadrant complaint, we have to think that probably the complaint is arising out of all these structures mentioned. Similar thing also in the left lower quadrant, that if there is any complaint here, you have to think of all these viscera. Indirectly, unless you know the quadrants, unless you know that the structures which are in that area, unless probably there is a situs and marsus, you should think the organs which are situated in that area. Now look to this picture. Always we ask that what is the transpyloric plane, and the other one is the iliac lines which divide the abdominal regions into nine. Nine means if you see the right hypochondrium, the epigastrium, left hypochondrium, left lumbar region, left iliac fossa, hypogastric region, right iliac fossa, right lumbar region, and the center is the umbilical region. Again, you see very classically, if you see the organs are related also accordingly. What are the organs situated in the right hypochondrium, in the right lumbar region, in the upper iliac fossa, right? So these regions and the quadrants we must know pertaining to the anatomical structures situated inside, which are taught in the good old days when we are in the anatomy class. Whenever we go probably to examine a patient, we must have an adequate history of the patient in his own words so that you can think probably what is the complaint of the patient, where is the complaint of patient, accordingly you want to examine the patient. Before going to examine the abdomen, first of all, there are some prerequisites that you must maintain your good personality. You have to introduce yourself to the person. You have to maintain the privacy of the patient, take a consent of the patient for examination, and maintain high level of professionalism. And whatever findings you are getting during your examination must be documented well. Before doing this, never forget that you are going to see the patient as a whole, not as a part. So do a thorough general physical examination in terms of his build, his nutritional status, his vitals like the temperature, pulse, blood pressure, and respiratory rate, and must see for whether there is pallor, icterus, cyanosis, clogging lymphadenopathy, or edema or not, because they are the distant clinical findings in any abdominal pathology. Look, on one side the patient is looking pale, the other side the patient is looking jaundice, that is the yellow. That means Somebody has some disease for which he has become well. Somebody has some disease, some obstructive biliopathy for which he has, or a hepatocellular disease for which he has jaundice. This is the clubbing. This is the cyanosis. Pedal edema. Most of the time we see that any abdominal pathology in terms of a mass and malignant mass, probably there is bilateral pedal edema. Or also in a case where there is a mass in the pelvis giving rise to lymphatic or venous obstruction can give rise to bilateral pedal edema. And if you look at this, say somebody has an abdominal complaint, and if you see a fullness in the supraclavicular region, this is clearly a varicose node. That means from the beginning, before going to the abdomen, you have thought that this is a metastatic node. That means you might be having a malignant disease. Always have also a good clinical examination to see whether he has the peripheral signs of hepatic dysfunction or not. This has just got a sentence before I go to the examination of the abdomen that we must follow this rule, that we must look before we feel. We have to feel before we listen. We have to listen before we think. And once we want to talk, then probably we must think before that. We follow always a golden protocol that in the order of examination of the abdomen, you have to inspect, then palpate, then percuss, then auscultate the abdomen. And after the inspection, palpation, percussion, auscultation is over, the examination will be complete only with a perrectal, or in a female, both perrectal as well as a pervaginal examination. The inspection is the most important thing. Once you look at the abdomen, probably you can get so many information. What are the information? And before inspection also, you have to have a good exposure of the patient in the entire abdomen, that is just to mid-thigh. The posture as well is supine and the patient must be relaxed. Relaxed means, that's why I told that you have to introduce yourself and motivate the patient so that patient also mentally relaxed with you. And it is always done from the right side and put in of the patient. You have to stand and then examine. In the inspection, the first thing comes the shape and contour of the abdomen. See, if you see one patient has a flat abdomen, it is a stuffed abdomen, it is a distended abdomen. You feel that probably it is a normal. Scuffed means probably malnourished. Distended means probably it is distended because of fluid, because of air, or because of some mass lesion. And once you have identified the shape and contour of the abdomen, you can get so many information. Then look at the umbilicus also, that you have to see whether what is the position of the umbilicus. It is normal or high placed or low placed, and characteristic changes has occurred or not. That means whether it is inverted or everted. Because if you find normally it's an inverted one, but if there is a hernia, if there is free fluid, that will give a signal in terms of a version. Then you have to see that what is the movement of the abdominal wall with respiration, whether it is moving perfectly or not. And by chance there is an underlying inflammatory pathology like peritonitis, the movement will be impaired, or there may be absence of the movement of the abdominal wall. Look at the condition of the skin over the abdomen. They give many information. Many times you see that the abdominal wall has become edematous because of the underlying inflammatory pathology. You have to see whether previous scars are there or not. You have to see whether it is a strias are there or not, whether which occurs in a multipara, whether there are sinuses or not, and whether there are prominent veins or not. Because once you find normally you do not see much of veins, but once the veins are prominent, it is the evidence of total hypertension. Then comes the most important thing that we see in obstructive pathology of the GI tract. starting from the stomach to the last, that you may get a visible pulse, visible peristalsis. That and this visible peristalsis may be of gastric origin, or may be of small intestinal origin, or may be of a large intestinal origin, and in a gastric outlet obstruction, the visible peristalsis will be from the left to the right. In a colonic one, transverse colonic one, it will be from the right to the left. And if you find out a small intestinal, it will be a ladder pattern type 1. And many times, with the visible pulsation that we see in the abdominal wall, if you see a pulsation, that means it is originating from inside. This may be a expansile pulsation, which may be seen in a very thin individual, or maybe a transport pulsation, which you will verify in the palpation. Next is we have to say whether the abdomen is normal, or in any of the quadrant there is a mass visible. So you have to find out whether this mass is visible for abdomen or not. And while inspecting the entire abdomen under whatever heading I have told, like this shape, the umbilicus, movement, stria, veins, visible pulsation, visible peristalsis, mass, always try to look at the hernial orifices. You can just ask him to cough and see any bulging at the hernial orifices, which may be from 2 points, that it may be there may be a hernia, or it may be this hernia may be because of the effect of the increased intra-abdominal pressure, because of gas, because of fluid, or because of a mass. And definitely, you always complete your inspection findings by examining, looking at the genitalia, because you have to look to the genitalia. Many times you get a mass, but you forget to examine the genitalia. There is a mass in the abdomen, and there may be a testicular tumor. So, genitalia examination is a must. See, this is how you must expose and inspect in detail. These previous scars you must see, because many times people have been operated for some other reason, and the scars are very important. And whenever you see the scar, you have to see by two things in the inspection. Ask him to cough. If at all there is a hernia, there will be a protrusion through this scar, which is the telling tell that probably there is a incisional hernia. And once you have seen these scars perfectly also, your next laparoscopy or laparotomy, you will plan accordingly, because the scars are the telling tell of underlying adhesion. Look, this is the stria that we commonly come across in a multipara, but these are the dilated veins. Normally, we do not see the dilated veins. Once we see the dilated veins in the anterior abdominal wall, we have to think of a portal hypertension or some other form of venous obstruction. This is very good that you see that normally you do not see these loops of intestine like this. And once you see this is going just like a ladder pattern. And once you see that the movement, you see this is called as a visible peristalsis. And once you see the peristalsis, you have to see also in which area it is, what is the direction, whether this is from left to right or right to left, or it is a ladder pattern of peristalsis. After completion of your inspection, you have to go to palpate. What is the purpose of palpation? The purpose of palpation is to find out any mass. Second, you have to find out any organomegaly. Heart, if at all there is a scar, with whether you have to see whether there is a incisional hernia or not, and identify the size of the gap and the contents also. So before palpation, never forget to warm your hands. The position of the patient is very important. That the patient must be supine, arms at the side, lower limbs flexed at the knee and hip to relax the abdominal muscle, which will facilitate your palpation. And this palpation may be a superficial palpation or a deep palpation. Because many times without a deep palpation, probably we cannot palpate the organs. Whenever you go for a superficial palpation, always maintain the principle that start from the area of least pain. Otherwise, if the patient has told that which is the most painful area, you press it, palpate, start palpating from there, there will be pain, tenderness, and automatically the patient will maintain a voluntary rigidity. So always start from the area of least pain. Observe the patient's face for pain is there or not, and palpate for tenderness at any site, and first find out whether there is guarding or rigidity or not. And this guarding particularly find out whether this is localized or generalized. Because if it is a localized inflammatory pathology inside the abdomen, there may be local rigidity, and if it is a peritonitis, there may be a generalized rigidity. Many times we have to go for a deep palpation to find out the organomegaly, particularly the liver, the spleen, and the other solid masses inside the abdomen from other origin. Whenever we go for a deep palpation, particularly this liver, start deep palpation in the right iliac fossa and gradually work upwards towards the costal margin. Because if you see, many times you put your hand, there is a hepatomegaly, you may not find a margin. But once you start from here, right iliac fossa, gradually go up, you can find the intermargin of the liver and then go to the surface. So that is why start a deep palpation in the right left fossa and gradually work upwards towards the coxal margin. Enlarge liver, descends and push against your finger. Whenever you palpate the spleen, normally the spleen is not palpable. Unless it is 2 to 3 times enlarged, it cannot be palpated. And you know that the direction of the splenomegaly always is from this towards the right iliac fossa. So start your palpation from the right iliac fossa and progress towards the left costal margin. Because many times same similar thing happens in the liver. As the liver is enlarged, put your hand, you'll find a mass, but you cannot feel the margin, and you may miss also. So spleen also start from the right leg fossa, go to the side so that you can find out where is the margin and then assess how much the spleen is enlarged. Palpation in this, many times the spleen is such a organ that it is massively not enlarged, you may not be able to feel. So you have to modify the position of the patient. So palpation of the spleen in the right lateral decubitus position. See the patient's position is changed so that you go on palpating. Simultaneously you are pushing the wall with another hand so that during each act of inspiration you can feel the sharp margin of the spleen touching your finger. The third organ inside the abdomen is probably kidney, bilaterally placed in the lumbar region, which are very difficult to palpate many times, particularly in a muscular and a obese individual. For that probably, we cannot palpate with only one hand and you have to use your both hands. That is why this is called as a bimanual palpation. See, that you put one hand behind, one hand front, and then you palpate here. And if it is big, you can feel it as such. Otherwise, push from one hand, it will feel on the other hand, which is called as a ballotment. Ballotment means it is tossing about. So there is a space, there is a small structure, just like a ball which moves. So for the kidneys, if it is possible to palpate it by manual palpus is good. Otherwise, ballotment test can show this. Palpation of the abdominal aorta. you must, if at all, you have seen a pulsation, and once you put your hand, you have felt also a pulsation or a thrill many a times, which is most of the time because of the aortic aneurysm, and these pathologies mostly in the Western countries, but most of the time to feel the abdominal aorta, we put both the hands like this so that you can assess why it is this margin and what is this margin. The next most important point that most of the time we get a surgical pathology in the abdomen, that the appendicitis. It's acute appendicitis where the patient presents with pain in the right iliac fossa. And once it is in the right iliac fossa, we have to find out in which point it is, and particularly this point is called as the McBurney's point, which is between the lateral one third and medial two third of the line joining the umbilicus to the anterior superior spine. And once you find out a maximum tenderness in the right leg fossa over the McBurney's point, probably almost you clinch the diagnosis of appendicitis, which will be subsequently assisted by further investigation. And while palpating this, if you find out rigidity and there is a rebound tenderness, you just press it like this, release your hand. If at all there is a pain or tenderness, you have to say that this is called as the Robson side. The commonest pathology is the gallbladder pathology. Now look here, if you see to this picture, this is the costal margin and you see a swelling here. And once you see a swelling always inside the abdomen anywhere, just examine it as a swelling in terms of size, in terms of size, in terms of surface, consistency, tenderness, local rise of temperature, then perimeter of the swelling and movement with respiration. Now, if you see that this is projecting below the coastal margin like this, and you are able to see that this perimeter of the swelling is visible like this, but the upper limit is not seen clearly, you have to say that probably this mass in the right hypochondrium below the coastal margin is arising out of the gallbladder. And whenever you see a gallbladder, you have to see for certain things, that size, then surface, consistency, and most important is the movement with respiration. And the another thing is you cannot get the upper limit here, and you cannot insunate your finger here. Next thing is, once that is why I told that once you see that probably it is a gallbladder pathology, you, even if you have forgotten the general examination that whether the patient has jaundice or not, look at the eyes again. So gallbladder signs are there, certain signs that if you find out a patient in a jaundice with jaundice, a palpable gallbladder seldom occurs due to this. So once you get the presence of jaundice, progressive jaundice, painless jaundice with a palpable gallbladder, make sure that think that it is not because of the stones, but because of some pathology. Most of the time it is a periampullary pathology. And usually, before this Coriolis's law, every student must be well versed with the Murphy's sign during the palpation of the gallbladder. That palpation in the right costal margin during inspiration results in sudden cessation of inspiration, which is called as a catch in the breath. That means if you are getting this Murphy's sign, probably you are thinking that it is a acute cholecystitis. Most of the time we get confused with a splenomegaly or a rhinomegaly. We get a mass in the left hypochondrium projecting below the costal margin. We get confused whether this is a spleen or the kidney. But there are certain basic differences to declare that yes, this is a splenomegaly or yes, this is a rhinomegaly. And once this is a spleen, you can insinuate your finger between the swelling and the costal margin, which is never possible in a splenic swelling. But in a cranial swelling, it is possible to push fingers between the kidney and the costal margin. If you find out the spleen in your anatomy days, you have been taught that the spleen has a notch and you may be able to feel it, but in a renomegaly, there will be no notch. And spleen will always move so freely with respiration. Kidney has no movement or very restricted movement. So these are the few points one must remember to distinguish whether this is a spleen or the kidney. And all these informations are obtained by the clinician, by the clinical examination. It is not that he will say that don't worry, I will subject the patient to an ultrasound or a CT. No, it is the job of the clinician to distinguish and declare that the swelling is arising out of which organ probably. Whenever you examine the abdomen under the inspection or the palpation, always you have to look at the groin hernias or and in fact in the abdomen you have to see all the sides of the anterior abdominal wall hernias starting from the epigastrium, there is the epigastric hernias, the umbilical hernias, the incisional hernias, there may be a spinal hernia on the lateral border of the rectus or the inguinal hernia or the femoral hernia. In other words, examination of all hernial orifices should be done. After our inspection on the palpation, we have to percuss. What does it mean? Percussion. What is the purpose of percussion? One has to understand what is the purpose of percussion. Because once you have seen a distended abdomen, you have to be mentally clear. This distance and this fullness is because of what? Air or fluid. Second point, there are so many organs as per the location. Normally, in front of them lies the intestine, which may be filled with gas. That is why you have to percuss, and if you percuss like this, that tap over the finger which you have put, normally the percussion note will be resonant. But it may not be resonant if there is a underlying mass here like a hepatomegaly or there is an underlying mass here like a splenomegaly. And to know that that normally the abdomen is tympanitic all over the abdomen, all quadrants must be percussed. And this is the way how you percuss. Put your hand over the middle finger. You just tap it with the other finger and you'll get either a tympanitic note which is normal or a dull note. If you find out dull, you have to find out what is the cause of this dullness. Whenever you are percussing the liver, what for you percuss? Because now if you ask a student, he will say that why should I spend my time? My radiology will define everything. That what is the liver? Because if I say that this is the liver, there is a hepatomegaly, and why you are wasting my time by doing this clinical examination saying that liver enlarges downward, liver enlarges upward, why should I do like this? But in a part of the clinical examination, we have to find out what is the span of the liver. That means how far it has come down below the costal margin. So if you percuss from here, if you go on percussing from here, you say that this is the inferior margin of the liver and say that this is 4 centimeter below the costal margin. And similarly, once you see these also, you have to find out what is the upward enlargement of the liver because most of the time this dullness starts from the fifth intercostal space. If there is an upward enlargement of the liver also, you go on percussing from above or downwards. If there is a hepatomegaly, there will be early dullness which will be located. Similarly, when you percuss over the spleen, you have understood that enlarged spleen expands inferiorly and medially, replacing the resonance of the stomach with dullness of the solid organ. So you go on percussing from here. If you are percussing over this, over a spleen, enlarged spleen, you will get a dull note on percussion. Many times, this is another method of doing the percussion for a spleen. Patient will be on supine position, percussion in the lowest intercostal space along the anterior axillary line, and there will be a resonant note if the spleen is normal. If there is a splenomegaly, there will be dullness. Look, this is the point where you go on percussing. So these are all indirect methods. To find out another method is also Nixon's method, that you maintain a right lateral decubitus position, percuss from the posterior, that was the mid-axillary line, this is the posterior axillary line where you are percussing. The upper border of dullness normally is 6 to 8 centimeter above the costal margin, but if it is more than 8 centimeter dull, it indicates a splenomegaly. You can just forget these two methods, but always this percussion method you must remember in mind. These two are additives. Next is, once you have seen it is a full abdomen, it is not a, it may be fluid. So this fluid may be small in amount, medium in amount, or totally massive in amount. You have to take certain clinical methods by which you can know that yes, there is fluid. So most of the time, if it is a cross ascites, it becomes easy that you just put your hand like this. You just put your hand like this on one side. Somebody is helping you by putting a hand in the center. You just make a tap here. Since it is a water filled compartment, there will be a thrill which will be felt by this hand. So this is called as a fluid thrill. It's very easy if probably it is full of fluid. But problem occurs when the fluid is less. And when the fluid is less, it goes to either side of the abdomen and some remains in the pelvic area. So right now, if I go on percussing like this from the midline towards the lateral one, I'll get a dullness here. Now, if you just change the position of the patient, make this side up, wait for certain time, percuss it, it is tympanitic. You can reverse the test. That means there is a dullness and you are shifting it. So it is a shifting dullness. Shifting dullness denotes less of fluid. And fluid fill denotes that is a massive ascites. And in good old days, this test was also done that you cannot detect the fluid unless it is 500 ml or more. This test was done puddle sign where you patient examine the patient in the knee elbow position so that the fluid becomes dependent, and if you percuss you can get that, which is very tedious and no more is practiced because better methods have come up. So examination of the abdomen to find out the presence of fluid is a must. If it is not clinically detectable, many times radiology, like the ultrasound detects that there is fluid, but clinically we must exclude that clinically there is no evidences of free fluid in the peritoneal cavity. After your percussion is over, probably auscultation is there with the help of a stethoscope. And whenever we think of auscultating, what is in our mind, what we are going to listen, most of the time we are going to listen about the vowel sounds. The second thing also, many times we may get the bruit from some vascular problem. We'll discuss these two things. That whenever you are auscultating about the bowel sounds, listen for 1 full minute. Note the pitch and frequency of the vowel sounds. Normally it occurs every 12 to 15 seconds. If no vowel sound is heard, listen for full 2 minutes before stating that there is no vowel sounds. And if there are no vowel sounds, what does it mean? That means the gut is not moving. That means there is a ileus, whatever the cause of the ileus may be. So vowel sound is very, very important. It can tell you that there is ileus. Second, it may get exaggerated more than the normal. If at all it is exaggerated, it represents that there is some obstruction. To overcome the obstruction, the motility of the intestine has become vigorous and you get the increased bowel sound. Beyond the bowel sound, many a times, you may get a venous hum over the right upper quadrant due to photosystemic collaterals in portal hypertension. There may be a splenic friction rub over the spleen in the 10th rib area in cases of splenic infarction or sequestration. You may get an aortic bruit, which is uh, very unusual in our part of the globe because of the aortic aneurysm. And many a times there may be a renal artery bruit because of the renal artery stenosis, and the clinician go on searching for this in a case of hypertension when it is excluded from all other causes and think that you probably it is a renal hypertension. Probably by now I have given you an overview of the general examination of the patient as a whole, inspection of the abdomen, palpation of the abdomen, percussion of the abdomen, looking at all the hernial orifices in the abdominal wall. I have said that it is not complete unless you do a digital rectal examination in a male and a digital rectal examination plus a pervaginal examination in a female. Now you must be thinking that what is the purpose of doing this? Many a times it has been said that if you do not put your finger in the rectum, you may put your foot inside that. That means they all routinely you must exclude any rectal pathology. This is number one. Number two, many times in the hypogastric masses, you put your finger in the rectum or in the vagina and palpate from the hypogastrium, which is almost equivalent to a bimanual examination that we conduct in a renal swelling. Third, many a times by doing a perrectal examination, we may get the evidences of the peritoneal metastasis because of some visceral malignancy inside the abdomen, which presents in the lowest part of the peritoneum, that is in the rectovesical pouch or the rectouterine pouch, in which is called as a Blomer's cell. So the purpose of the rectal examination is very clear that while inspecting, you have to exclude any perianal disease like a common disease, abscess, fistula, hemorrhoid, or epica, and do a good digital rectal examination to find out any mass or polyps. In a male, find out whether there is a prostatomegaly or not. Always assess what is the sphincter tone in the anal canal, and once you remove your gloves finger, see whether this is blood tinged or not. This is just to see how are you going to do a digital rectal examination, but you just remember that the examination of the abdomen is not complete unless you do a digital rectal examination or a vaginal examination. To conclude, probably I can say that abdominal examination is very essential to arrive at a diagnosis. This gives multiple clues for further approach and management because it is very simple that if you are getting a patient in a jaundice patient, who had waxing one with cholangitis, and you are not getting a gallbladder pathology, palpable gallbladder, you are thinking that it could be a choledocolic gases. In that situation, beyond a ultrasound, the investigation of choice will be a MRCP. Come to the other thing, that if you are getting a progressive penless jaundice, you are getting a palpable gallbladder. You are thinking that probably it is a periambulary. Your investigation of choice will be a CCT, but not a MRCP. So that means your good clinical examination will give a clue that what should be your subsequent radiological or endoscopic evaluation. It is not that. Don't will not put our hand, will not examine probably, just send the patient for a battery of radiology and endoscopic evaluation, which will give us the clue. So again I say that it is essential to arrive at a diagnosis. It gives multiple clues for further approach and management. And last sentence is very clear that nothing can replace the experienced hands of the clinician over the abdomen to recognize the emergent signs. Before probably I conclude, I can quote Dr. APJ Abdul Kalam that if four things are followed, that having a great aim, and whenever you examine the abdomen, it is not that it is a swelling in the stomach. You should come with a great aim that I will examine this abdomen and to find out a good clinical diagnosis. So if four things are followed, like having a great aim, acquiring knowledge, hard work, and perseverance, then anything can be achieved. Anything achieved means in an abdominal examination, a good clinical diagnosis can be achieved through your clinical examination, not by the investigations. Thank you. Thank you, sir. Thank you all.
Thank you, sir, for the elaborate actually presentation regarding the abdominal examination, and nothing beyond this will be definitely asked to a student. So this much minimum is required, and also it's for the postgraduate also. So I also welcome Professor Kapoor to share his pearls of wisdom regarding the abdominal examination. If he likes to add something, then we can take some questions, if at all, from the attendees.
ଆଉ କାଗଜପତ୍ର ଅଛି?
Any questions from any attendees? Directly can ask. Probably Kapoor sir is having some network issue.
Yeah.
So overall, it was a very nice presentation, sir, and thank you for just taking this wonderful class on abdominal examination. Still, I am also learning as I used to do during my PG days. So thank you all for joining this session. So next week we will be joining the same time with another presentation. So students, be prepared also, and you can put also questions in the WhatsApp group if at all you have, so that it can be discussed in the subsequent class.
Thank you. Thank you, Prakash.
Thank you, sir. Thank you, sir.
Thank you. Hope we are meeting at Calcutta again with Professor Kapoor on 14th, 15th, 16th, 17th.
Yes, sir. Yes.
Thanks for giving me the opportunity. Next time you give any
Yes,
work,
sir, we'll be giving you, sir, more
I'll do it more sincerely.
Yes, sir. Thank you, sir. Thank you.
Thanks
Sir.
a lot. Bye.